And we'll be getting started in just one moment. Okay, awesome. There we go. Local recording as well. Hi, everybody. It's so great to see you. Welcome to the Match Coalition, which is the Maternal Applications for Technology for Community Health Coalition. We're really excited to see everyone today. Some new faces as well as some familiar ones. We've got a great interactive lineup for today. We will encourage everyone to put on their cameras if they're so willing to do so. But in either case, definitely using their digital hand as well as using the chat window to participate in today's program. We have an amazing lineup that I'm glad to see and welcome both our co-chair at HIMSS, David Gray, who's also accompanied by Rachel. Hi, Rachel. It's great to see you. Nice to finally meet you, as well as our very own Valerie Rogers from HIMSS. For today, we are actually going to have a roundtable event, but I first want to make couple of acknowledgments. The first of which is the summer came and is leaving as quickly as it came. We're going to be jumping into the fall, and this fall, as you know, um, only happens every 4 years. It's one of the most crazy times as we are in election season, and the effect that, of course, that has on some of the things related to maternal health, as well as many other important topic areas for our nation are kind of all sort of still out in the air somewhere, but slightly put aside as there's this focus on presidential elections. And so with that, we're going to be, instead of having a virtual Hill briefing this autumn, we are still instead going to be having a technology showcase coming up in the months of October and November. Equally, it might put a little of a different spin onto our legislative updates, but nonetheless, we still want to make a moment for that today. We'll make a moment for any comments, David, that your team would like to share in terms of the legislative landscape. And then we're going to pause and allow for anyone who has any updates regarding whether it's a local, state, or federal activities that they'd like to let others be aware of, or any celebrations on their organizations that they'd like to share. You are certainly most welcome to do so. And then from then we're going to actually transition over to our roundtable discussion on maternal health information management, which will be facilitated by Valerie Rogers. So with that, David, I'm going to pass it over to you. Any legislative updates, anything that we should have our eye on in terms of activity happening on the Hill?
Um, sorry, excuse me.
Mhm.
For better or worse, no. Congress is back. Sorry, I dropped my pen. Congress is back now for the next week or two until they can figure out how to keep the government funded past October 30th. And then they are out until middle of November as people campaign for elections. You know, I will say that right now people are starting to angle toward getting some priorities into any year-end massive lame duck package, particularly around healthcare, such as telehealth for Medicare, and a number of other healthcare priorities. The Black Maternal Health Coalition held an in-person stakeholder summit. It was actually in Chicago this year. Last year it was in DC, and I attended. I wasn't able to attend this year, but we are trying to keep the pressure on Congress to move maternal health legislation, whether it is the Momnibus, standalone Momnibus bills, or other maternal health legislation. So that is something that we will continue to ask Congress to consider in any year-end package. But that's kind of where things stand. Not a lot of optimism for really anything to get done at this point, but we'll continue to push for something in the final few months of the year.
Okay. Well, I guess we can all agree, no surprise to that one, unfortunately, for this time around, but we are very appreciative of the information you're able to provide for us, and we're very hopeful that this topic will still remain a topic that's front of mind, and we, along with other organizations, will continue to do our efforts to make sure that that is the case.
Yeah, I mean,
So
I'll
with
just
that,
add,
yeah,
sorry, last thing I just
yeah,
remembered, there were a couple of legislative bills that did move out of the Energy and Commerce Committee earlier this year that I don't believe were brought up to the floor, including the bill that would sort of reauthorize the maternal mortality review committees and strengthen them, and some other sort of childbirth and maternal health legislation. So there is there are some vehicles and there are some opportunities that we could see in any package. So, you know, like, as I said earlier, we're just going to make sure that we focus our advocacy in the maternal health space on this. So,
okay, very good. Anybody have any questions about the legislative update? All right, thank you, David. We're going to open the floor now and allow anyone who has any announcements that they'd like to share to take a moment now to raise those if you wish. We do have coming up in October, trying to remember the dates now. I think is it the 20th April, October the 20th is the health um, is our Health 2024 conference. Sarah, will we be seeing your team out there at Health this year in Las Vegas?
We will be there. We will have a small booth as well. Would love to meet with
Awesome.
anyone who's interested.
Fantastic. Thanks for confirming that. Anybody else, any updates or activities? We here at Reach Healthcare have our annual Happy Mama Expo, which is taking place on October 19th. That is the largest maternity fair. Of course, that's a to the public-facing event to support families on their maternity journey. And it is open to the public and no cost, and anyone is welcome to participate. If you have an organization who is interested in having your brand and service awareness at that event, we would welcome your participation. All right. And with that, I'm going a last call. It's great to see Wanda Irving. Hi, Wanda. Did you have anything you'd like to add in terms of some activities that are going on with your organization or others that you'd like to share? All right, Wanda's being quiet there, but we are so honored and grateful to have her organization with us this morning. All right, let's go ahead and get started. So we're going to pass it over to Valerie Rogers. I'm first going to just open the screen for a second and grab this link. We're going to focus on the area of priorities that are related to maternal health information management. This is a survey that had been put out earlier this year, beginning in July. We're going to use the primary points of this survey to drive a roundtable discussion for today. I'm going to pause my screen here, and Valerie, if you don't mind, I'll actually put you to spotlight. I'll try to get fancy, and maybe I can split screens between you and the survey itself.
Yeah, or focus on the group. That's fine too.
Okay. Okay. All right.
So good morning, everyone. Again, Valerie Rogers here with HIMSS. I work with David and Rachel and a smaller group of individuals on a variety of topics that primarily for government relations focus on state legislation, but some federal legislation, with David and Rachel sort of taking that congressional lead. For the past couple of years, I've engaged with the Match Coalition and others around ways in which HIMSS can support one might still say is a crisis, the maternal mortality crisis. So the purposes of this survey are very much focused on maternal mortality. We are hoping over the summer, we put out this survey, we were hoping to get some robust comments around the impact of some of the current actions that have been taking place. We are aware at the state level, there's been quite a bit of movement with maternal mortality review committees, with states, say like Pennsylvania, that have pushed forward more focused data analysis and data collection around maternal mortality and reporting that back to the state for better sort of quality improvement of systems and services. And so I think we're kind of a bit at a crossroads in terms of, where do we really focus our attention next in reducing maternal deaths? So in collaboration with Fran and David, thank you both for allowing me to have some time today on your agenda. We'd like to just sort of talk through some of these questions that we put forward in the survey. And, as you can see with the survey, one of the very first questions that we asked is related to, so go away. Sorry, I had like some screens pop up and I don't know why. Sorry about that. Basically, as you are envisioning what is optimal care for pregnant and postpartum women, what are some of the primary topics that you believe health IT experts should know about making information useful for clinical care? And I would expand beyond that. I believe in the survey we asked for sort of 1 to 3 sort of primary topics that HIMSS potentially in coordination with Match could push forward around health IT. And I don't know if David or Rachel, if you have at your nifty hands, the HIMSS has on our website some of the previous comments and recommendations we put forward for states around what they can do. But we also realize now, as things have shifted over as I mentioned, the last couple of years, with the prominence of AI, the prominence of more data sharing as it relates to some of the data modernization that's rolling out through the CDC, through HHS, as well as CMS, that also opens the door for more information, potentially more data that can inform and then equip those of us working to prevent or eliminate maternal mortality in the US with more robust information to fight that fight. And so as you think about that and that landscape, what would you say are, or what would you envision are the 1 to 3 sort of primary areas or topics that health IT could be working on, or that could be leveraged, I should say, to help us fight that fight? And I'll just stop there and see, like, if you any questions or clarification, but I'm really interested in sort of knowing how you all are feeling about how things are rolling out and how we can leverage more data, more information to improve outcomes. So I'll just stop there because I think I just had the longest run-on sentence, but I'll stop there and see what you all think. Any thoughts?
Well, I'll tell you, as people are starting to formulate their ideas, just kind of pulling from some of the survey results itself, one individual had pointed out that they really wanted to be able to use data to help individuals know when to seek care. And interestingly enough, what also provide some steps on what they should do when they feel as though they're not being listened to. Like, where do they go to from there, and how can data information help in that process?
Mhm. I mean, I think that's super important. And I mean, you could also look at this through the lens of digital solutions, through the lens of advocacy, through the lens of more state actions around this particular topic as well.
This is Kay. I'm from the
Okay.
CDC. So one of the things that I want to kind of like talk about basically is, you know, are the data interoperable? You know, the data is from this information management. There are a lot of places in this country, they don't really have like specific health information systems for maternal health. What they have is scattered within the modules of an EHR, you know. So that's one. So now are these data interoperable? Because one of the issues we've been having, especially with regards to USCDI and our USCDI Plus, is that there are a lot of data elements which we propose that has now been moved into production over there because they have some criteria which they use for movement of some of these data elements. For example, one of the data is that the data element has to be able to be exchanged between one electronic health records to another. And that is not still happening because a lot of the data elements are not even HL7 compliant. So I just wanted to kind of like chip that in there for more discussion.
I'm so glad you mentioned that. I know for our organization, just, not even on a national level, but on a state level, we've signed the agreement to participate in the data exchange. There's what we call the data exchange framework. And, there's a lot of information about the value of this exchange, but the language is very convoluted, and it doesn't really even directly like tell us, okay, where are we supposed to send the data? What shape should our data be in before for us to know that are we in a ready state? Is our data good enough in the format that it's currently in? We have no idea. And then, yeah, I mean, that's what then leads us to hiring, right? I mean, we have a contractor whose focus is to do just that. But it seems like there's just like, I don't know, if I were hiring a vendor who was going to, maybe we were adopting their platform, and Sarah, maybe you have some thoughts on this. If you had a client who was coming to you and wanting to utilize your RPM, then you sort of would have a kit for them sort of in place to kind of help them to ready set themselves, right? It's not like they're just on their own in that process. And in many respects, as much as there is what they call these technical assistance marketplaces, this notion of data exchanging is not really outlined very clearly, not even, it doesn't have to be sophisticated, but even it doesn't even touch the way an organization like Sarah's, as an example, might have their systems structured, or the way that they enroll organizations onto their platform. I mean, I don't know if you care to comment on that at all. You don't have to go too technical, but yeah.
So for those who are not aware, Baby Scripts is a maternal RPM program, and we have about 70 major health systems and some major payers with some very sophisticated integrations. Yet we still have some major data access issues for us to fully see the life cycle of a patient, or to be able to report back the impact of our program. And, you know, we've been doing this for 10 years and we still really struggle. And our providers really struggle too from their end, even though they have access to all of the EMR data. So and payers want access to that outcomes data. So it definitely is a challenge that feels so big, even though, you know, we've been doing it for a while. I don't know if that answers the question, but that's just some insight from like our perspective. But we have, you know, we have recommendations to health systems to say, hey, you want to stand up a system, this is our recommendation. You want an integration, this is our recommendation. And we at least have some starting points and guidance.
Right, which is a little bit different from what we've experienced. Like when it comes to working with the state and sharing data with the state, again, I don't know where I'm supposed to, that was the first question when we hired the contractor. It's like, okay, where are we supposed to send this data? How are we supposed to access it? Where are we, like, just the basics, like, where's it to go? Like, is there an address? Like, where, like, you know what I mean? Like, where's the digital address, of course, you know, where is the address where we're to be sending this data to? And what is the file structure? Like, what's the map? We don't, none of that is made. It's just like this sort of black hole. And that makes it challenging. Valerie, you're going to make a remark.
Yes, I was actually really glad, Sarah, that you brought up the payers, because I think they have been a little bit missing in this conversation. I was reading, you know, like the White House blueprint for addressing maternal health crisis. And, you know, one of the primary goals there, in the blueprint is, I think, goal 3. That really looks at or really pushes advancements in data collection, standardization, harmonization, transparency, and also supporting research. And I mean, I think that is such an area where not only looking at EHRs, but our payers could really help deliver much more robust information that may support causal research or looking at root causes for some of these issues, which I don't think are necessarily individual in every case, but would quite much also look at systems, health systems, and how they are seeking and approaching maternal health. And particularly in light of really some really high level missteps we've seen with women who postpartum have had major issues. Like, of course, you always think about Serena Williams, who was one of the most vocal, but there have been several others. So I'm just wondering from this group, is perhaps that is a particular call to action of really engaging payers to really kind of stand on business, if you will, in terms of bringing forward more information. I am not quite sure how that can happen, but I feel like there is definitely an advocacy-wise an area which we could certainly strengthen. I'm just curious what others think about that.
John, I don't know if you're on mute. I know you in the past have had so much experience with collaboration efforts with data management informatics. I'm not sure if you're on mute or not, if you'd care to, or if you would even care to comment, but would love to hear your perspective if you so choose to share. And while we're waiting on others to make a comment on it, I struggle a little bit with payer organizations because, you know, their data sometimes it's kind of like already it's a scrub of data to serve the purposes of reimbursement. So it may or may not capture the essence. And also there are holes as well, even for providers. So I gave you a great example. Someone said I was at this regional event 2 weeks ago, and the comment was they were questioning doula's engagement and ability to help in the reduction of cesareans. And of course, we know there was an increase in cesareans over the course of COVID. So then the numbers, we're always looking retrospectively. We seldom are looking in real time. So this retrospective review of what was happening during COVID showed this elevation, and therefore they weren't necessarily seeing this indirect correlation, right? The number of cesareans going down with the increase in the number of doulas. But the problem with that is that we're not actually capturing the data that would lead us to know whether there was or was not. In other words, in most instances, what ends up happening is the conversation around having a cesarean is brought to the table. A clinician will come in, an OB will inform that if we're not seeing progress or we're not seeing A, B, and C, then we're going to have to move towards a cesarean. And then if it turns out that we have a vaginal birth, then it's just recorded as a vaginal birth. It's not indicated that there was ever a dialogue or discussion around potentially a cesarean and that we had avoided a cesarean. That's not captured. All your data is going to show you is it was either a cesarean or a vaginal birth, but not the number of encounters or incidents in which there was the potential or potentiality of having a cesarean, but it was diverted. And so, there's like this impartial, like incomplete data or picture of what's happening. So we're not necessarily, and that's just one example, it's an easy example. There are many other examples, but we're not really capturing that. And so the story that gets told, or from where we are deriving the data, might show a skewed perception of the reality because of how we're collecting it or what we're not collecting, and for what purposes the data is being collected for. And I find more of those inconsistencies when it comes to payer organizations and the data that comes out of them, which doesn't mean the data isn't bad. It just means that it's just telling a different story. I don't know if anybody else would care to comment. Josh, perhaps would you like to share any thoughts?
I don't have any thoughts on that right now. I'm kind of new to the group. I'm just trying to learn what it is you're doing. I just got the invite this morning. Thanks.
Okay. What organization, Josh, are you representing?
I'm actually working on a startup that's actually working on. I have this assumption that there's certain data that you want to get directly from patients, and what that might do if you blend that with data you're getting from providers and payers. And the assumption I have is that actually, and I don't know the right form to ask, so that's why I just joined. But what I'm trying to determine is if I were able to give throughout the course of the pregnancy size information and scale information of the patient and how things change, as well as size and scale information of the baby, would that potentially help in understanding how well the birth is progressing and then the baby progressing after that? And what I'm talking about is using computer vision in a mobile application, which would then help understand as things size and scale and different other elements that might be valuable, including like patient's pulse ox rates and things like that you can actually get now through computer vision. So I'll pause. If anybody has any thoughts on that, I would really appreciate it pointing me in the right direction.
Well, I'm going to poke you a little bit further on that one, because when you're in doing so, what data points then, and interesting enough, you mentioned patient information. So in the context of Valerie's question around what you're envisioning to be able to take out of, to capture, and I got to go back to what the question actually was. Valerie, you got to help me here.
So yeah, as you envision optimal care for pregnant and postpartum women, what are the 1 to 3 sort of primary topics or issue areas that you would like health IT experts to know, or that you would want to bring forward, that would make that data more useful for clinical care, but also for a range of services for women, both pregnant and postpartum.
So it's sounding like, Josh, you're wanting that what would be beneficial is the data coming actually directly from the patient population. Is that right? I mean, I'm just kind of
That's
parroting
correct. I'm
back.
trying to figure
Okay.
out what data there exists, because if you already have it, you don't need it, right? You already have it. But if there's data that's missing that you would need towards a proper diagnosis or something like that for better outcomes, if I can understand that, I can determine to what extent I can capture some of that in a patient experience perspective. That's an easy enough experience where you get reliable data, and it's not necessarily something that becomes onerous on the patient to, type out every day, oh, I ate this today, or I had this, that kind of stuff ends up being too onerous, and you don't get the data anyhow. Does that make sense? So I'm trying to thread the needle of optimal care and versus ideal. Me,
Uh-oh, Josh, it sounds like you're breaking up on us there.
Oh, sorry.
Oh, that's okay.
Can you still
But
hear
yeah,
me there?
yeah, we can hear you now. That makes sense. I mean, I guess like it sounds like more specifically prenatal data that you're looking for, and you're looking for episodic information directly from mothers. Is that right? From birthing people?
Correct. And then also, to some extent, I want to actually go into, after birth, there's different times when the children may not be getting the right nutrition or other things, and it causes other issues that you can actually pick up on if you had basically think of it as a AI that's a doctor sitting with the patient all the time, both the mother and the child. So at that point, what could you do with if you were in the room? What would you do? What would you say to help have better outcomes and on through the birthing process, but even post? What would that be? And then what's missing in the model that we could actually get if we could have a nice, elegant way for the mother to actually interact with the data, and specifically the application. My focus is on building applications that are super easy for somebody to use, a lot of AI behind it to make it easier for somebody to interact with. And that's actually where what I'm missing is what's the problem, and obviously there's mortality and other things, but like what are the problems that solve with using to. So thanks.
Got it. I find that very fascinating because it's one of the things, Valerie, that perhaps we don't really articulate very well sometimes. There's this big emphasis on collecting data and data collection and consumption for our own purposes, right? Or in our own organizations, but not necessarily how that translates into data to be consumed by the patients directly, or leveraged by patients to help facilitate them in the process of self-care. And we're in an increasingly more consumer-driven self-help culture.
Yeah.
And yet we're still hyper-focused on our ability just to share data amongst ourselves, let alone not even touching on the patient's ability and desire to want to consume more data, but in ways that is digestible for them and that's actionable for them.
Well, and I think go ahead.
I was just going to say that's part of my assumption, because I've done a lot of work on customer experience and employee experience type of solutions.
Mhm.
And would be the patient experience. And I think if we can make it easy enough and elegant enough that someone actually then leverages it and they can actually have better outcomes. And I'll give you a crazy, weird example, but I saw my kids use something called Duolingo,
Yeah.
and the experience is so good, they can't stop learning Spanish. And so that's the, that's a great example of an experience, like in this case, a student experience. But if you could do that with healthcare, I have this assumption that I think if we could do something better like that, I think we could actually get much better outcomes. Now, at some point, I need to know what the optimal provider data set might be, the right kind of partners, the informatics. Like, there's too much there for me to uncover right now. I just need to see
Mhm.
where the problems are that we could collectively, I think if we can get focused on something that would actually be valuable, I think we could actually change the overall. I understand all the challenges because I've worked a lot with healthcare providers and insurance payers, etc. And some of the challenges, obviously, all the data, we have all these silos of data for good governance reasons. There's reasons why that exists, but it's also why the US system is so much more challenging than other countries to kind of get this data and act on it. But there's this whole other thing where we're in a new world where the end user can actually respond to things and self heal. And so that's a really interesting concept when you take it to patient care. So that's where I was like, okay, well, if we can get the right data, we can, and if there's data we don't have that we need, the patients, if they know it's for their own good, often want to share data, right, with the right provider. So there's this, I guess I just haven't seen what I'm thinking about anywhere in the market, which is why I'm so curious to see what you all think about it. Is it something I should pursue or drop it? It's not a good area.
Hey, no, go for your gold. And I'm gonna and I'm gonna actually make a comment. There's a comment in the chat from Jade who's saying that she's really apologetic because she's in the shared space today and unable to talk with her mic on. But she wanted to chime in, and she says, I would guess that if you're pulling data from either billing data, that is codes, or discrete data from EHR, I agree that you would probably just see CS versus, well, is that like claims and services data versus NSVD, and not be able to have the full story, which should indeed be documented. That is, provider conversations with patients, topics on delivery options and other attempts to forgo a cesarean or a C-section and pursue a vaginal delivery. I agree so much about the need. I also agree about the need to collect data with the patient's experience and our ability to pull non-discrete data, notes, other documentation that provides the entire story and not just the outcome. And she's saying, Josh, that she really agrees with you as well and is curious about how we can get to that type of data. So I think that is the $1 million question, right? How do we get to that kind of data, Jane? I think that's a really good question to pose there.
Just to chime in here, just from experience, both on the payer side and the provider side. So from a payer perspective, what we constantly hear is we don't know anything about, we need to identify member pregnancies. We struggle with that identification, and we don't have the history for that member and don't even really know that they're pregnant until after they deliver. Not always, but kind of that's a general stereotype for health plans. So for our deployments with payers, we do collect a lot of that social determinants of health, pregnancy health history data, and send it along to those payers to give them that insight. I think from our experience, they don't necessarily have the sophisticated systems to really understand how to use that and be actionable on that yet. From the payers or from the provider side, they think that similar data is valuable, but these providers only have like 10 minutes with each of these patients to be able to actually review the context of what's happening outside of that clinic is can be very, very challenging. So there's a resource constraint. So we at Baby Scripts totally agree that there's so much missing. It's just, how do you put it in a system, an existing data system that then becomes really easily actionable for either the payer or the provider. And that's been, I think, really challenging, especially when you're talking about one specific condition of pregnancy, one service line, when you're competing against a lot of other resources.
Mhm. Mhm.
So Josh, if you come up with something, I'd love to hear about it.
I'll work on it. Thanks.
Mhm.
Yeah.
I think the one thing I did ask, and I didn't know if anybody answered it, but I asked in the chat, I'm looking for repositories of what are the problems that we're looking to solve that we can't solve today because we can't get access to the right data. And I
Well,
think
that's
that
what,
helps.
yeah, that's what this
That's a
conversation
part of the
essentially is about.
conversation.
And that's the whole point of this conversation. And those are the data points that we've been collecting and that others have been very busy collecting as well. I would say that, there are consumer oriented groups like Dr. Shalom's map that are good places to go. And why is Kimberly Seals oh, it's called Earth. Earth is another great example. Those are ones that are capturing sentiment, patient sentiment. They're actually platforms where they're capturing that sentiment. And Earth is sort of like a Yelp for it's like the Yelp of maternal health in like maternal labor and delivery, if you will. So those are great places to go if you're, if you're looking for that kind of data. But essentially that's what we're all here to talk about, is how we can move towards more. And I see Dr. Bachman has Wanda just sent a note, but she sent it directly to me. Thank you guys for your time. She had to drop for another call. But you could always, Josh, follow up with Wanda as well, and that's Dr. Shalom's map and the amazing work that their team is doing in capturing those types of. I want to go further, so it's more than a sentiment. It is a real lived experience, right? It's more than just sentiments being captured in those environments, but they're not structured in a way, nor are they clinically oriented, that you would find those, except in an HCAP score, I suppose. That's where you would see data like that come through. And maybe it's also to, at least from our perspective and what we're pushing for through Reach Healthcare, and that is better definition about what we mean by the words, birth-friendly environment. What is a birth-friendly facility? What does that really mean? How do we define that? And I think that's more than just saying, oh, we're collecting data on morbidities and on mortalities in particular. There needs to be more defined around that. Dr. Bobby, it's so good to see you. How are you?
I was caught up in patients, so I apologize for being late.
Oh, no apologies necessary. We're just so thrilled to see you. And we were just about to jump into a next set of questions around maternal health data information management, but would love to, if you're okay, to just quickly give us your thoughts on things that your organization really envisions on being like maybe one or two, perhaps three things that your organization really envisions being able to do with the data. Is that right, Valerie? Am I stating this correctly? Be able to do with the data and
Yeah,
anything else
what should be a priority, leveraging this explosion of health data now at our fingers, given new opportunities for exchange across health systems, health and public health systems, et cetera. In addition, as was mentioned, I think a little bit earlier, any sort of technological advances. I mean, we haven't really talked about algorithms and leveraging them to support our work in maternal health, and particularly the focus is on preventing maternal mortality.
Mhm. I think that the issues that you're discussing are obviously key to, ensuring that, I mean, we as the United States are doing poorly overall with maternal health. And I think we have to get to the insurers. I think that they have to make sure that they cover all the services, because so many women are even petrified to come before for pre-pregnancy planning. So if I'm an individual who has no insurance, or insurance will not cover my pregnancy, I may enter that pregnancy with hypertension, with thyroid issues, with migraine headaches. I haven't had control of my blood glucose, and I'm already jeopardizing my health and the health of my unborn. Versus if insurance, and this is my area, I would get to the insurers and say, you have to insure, or you have to pay for individuals to get preventive health. And that's really the key to pregnancy planning for a healthy pregnancy. So that would be what I would recommend, is if we as a group could say, it doesn't start at conception, but it starts preconception, and that we have to make sure we're giving individuals the medications they need, the support they need, the health care they need, the screening they need before pregnancy, so that they enter pregnancy as healthy as possible.
Mhm, mhm. So what I find interesting about that is twofold. One, last year, actually, I think it was last year at HIMSS Global, at the luncheon, or maybe it was two HIMSS ago, we had a discussion. It was sort of where we broke everyone into different topic areas. And we had a table of folks from Cerner and a few other locales, and they were referring to this need to really focus around childbearing age, and creating programs that were centered on preparing individuals for family building, right? So that if that was something that they were considering, was to build a family, that they would starting to really help that individual go down a path of wellness to help build a family. Just like if you're going to do wealth building, that there are certain things you do to build your wealth portfolio. And and if you're going down a career, if you're building your career, there's certain steps and preparation that you do, right? Education and otherwise, to help you go down that path of building your career, and that we should be doing similarly for individuals when it pertains to their health and family building. But the paradox here is that on the flip side, payer organizations are creating programs. So they'll create, like, for coverage for doula services, or providing enhanced care management services for individuals who do have comorbidities, and and other conditions, perhaps even social economic, that put them in high risk categories, creating these what they call enhanced care management programs that are specific for birth equity. And around that, I guess it's like creating these navigators. What the paradox is that while they create the programs, they don't promote the programs. In fact, they put the burden back on the social agencies like ourselves, who were asked to go out, who are out there delivering these services, to identify their member population. And instead of them referring to us, they're looking for us to refer back to them, their own members, because there's no accountability on the part of the payer. For them, they feel that it's just enough that they created this program, but there's no responsibility or onus on their half to play any role in the actual enrollment. And Sarah, you've got a smile and a sort of a nod on your face. Anything you like to share there?
I just agree with everything that you just said. That's all. I mean, I think it's you know, we work with these plans that have these wonderful services that are totally underutilized because they really struggle to reach their members. So they go to organizations in the community, they go to digital health, they're just trying to figure out strategies to get referred in. And so there must be a better way, but I think they are very much struggling to do that.
And I'm
So,
just going to
oh, go ahead, please.
I was going to say, and this would be a great topic to write up an article and put it in the Journal of the American Medical Association, where all clinicians, not all, but a lot of clinicians are reading it to reach out and educate them, because this is not an educational venue that they hear.
Mm-hmm. Mm-hmm.
Good point. So
I completely agree. Mm-hmm.
I realize we only have like 4 minutes here. So before I do that, I did just want to just bring forth, and this is something we can ponder perhaps offline and maybe send some comments or some thoughts back to Fran. In terms of what I'm hearing is that we need a better data infrastructure for how information is shared and what information is shared, and that's across the spectrum. So that's payers, that's probably CBOs too that can participate. That's health systems, providers, and that's also the patient. And I just wanted to note, for the patient to have actionable information, there's a level of health literacy that also I think we haven't really touched on. So I want to bring that forward in terms of digital literacy as something potentially this group might consider as a priority as well. Are there any other infrastructure related to areas that you think are required for better maternal health outcomes? In the survey, and I hope you all would take the survey upon having this conversation. We talk a lot about USCDI data elements, so creating mandatory reporting around certain data elements for maternal health as something that's really sort of necessary, that we would like to see in all EHRs reporting on maternal health. You know, I would also say I have heard, and I wonder if you all have heard, sort of systematic problems with some of the vital stats information and reporting that's presented around maternal mortality and morbidity. A lot of folks not satisfied. I know it's gotten shorter, but it used to be a 10-year gap in which you could actually access the information in terms of how it was collected and reported back to the public for more accessible care. So those are a couple things. I know on the HIM side, we would love to hear more of your comments or your thoughts about how we might proceed, whether it's on the advocacy side or more education around those topics. So
sorry, I got kicked off
Okay.
of the internet. So I think one of the things, I know our time is almost up, is to look at how data comes in. It's very, very important. Data ingestion. In what form right now is data coming in? And I'll say far back to my point, how do we make data coming in standard clinical terminology languages of HL7, of LOINCS, of SNOMEDs, and others, because the more we do that, the easier it is to engage electronic health records, to be able to pick this data, work on it, and transfer it. Like we are in the public health, we like to receive a lot of data. Most of the data we receive right now are in form of surveys. How do we convert surveys to standard clinical terminologies? So that it's easy to electronically put it into the system, into the various systems. So, and Valerie, I saw a little bit what Fran on the questionnaire. I don't know if you all can add something like, because basically there are very, very few maternal health information systems. Very few. So I think if you can add, do you have a module in your EHR for maternal health? Because Cerner is encompassing, then some of them have scattered information on maternal health all over the different models they have. So if y'all can add that or change the verbiage, that would be great. Thank you.
I love that. And what we struggle with, on the non-clinical side, right? Because doulas are non-clinical, is that while all of those things are helpful, we're using an EHR, but we had to actually revert away from the maternal health module that's in the system, because what it collects is not the data that we're collecting. But yet, I mean, there is some, obviously, like, we're getting, okay, what was the EDD? Like, what was the, the estimated data delivery, and what type of delivery was it? Those types of things are standard, but there's a lot that we're capturing that doesn't even fit that, but yet impacts the pregnancy and choices that mothers are making to seek care or not seek care throughout the pregnancy. And you're exactly right. We don't, where do we put that? And I think, like, I'm excited for opportunities potentially with AI to assist with this, right? We would think that would be a great, maybe that's a hackathon that we put on. Can we experiment with taking multiple data sources and see if we can digest it and get it to come out on the opposite end with everything, being in language and terminology that is standardized, because we do need to figure out a way of doing that. But it just becomes challenging because you've got various stakeholders are participating in the contribution of data, but they're coming at it through an entirely different lens.
Right.
And how they capture. Yeah, please.
No, I was just going to say thank you, Dr. K, for that insight. I think, maybe we can relaunch the survey, Fran. And what I might encourage folks on the call today is, once we relaunch, maybe to share that with the community, so we could get even broader perspective of folks who are working on the technical side, as well as who are working directly with patients, as a way to get some additional comments. And, to that point, one of the main things that we hear at HIMSS around reporting some of this information or inputting the data is, it's burdensome. And how do we prevent provider burden, clinical burden? And I don't think that we want maternal health, for sure, to be captured or seen in that way. It shouldn't be. And I see Dr. K has a comment. And so maybe that's another way that we couch that. How can we make it more systematically and streamlined, such that it doesn't call or add to any perceived or existing clinical burden? But Dr. K, you had a point.
Yes. And the only way to do this, to prevent this burden, is to automate things. And of course, I think Fran mentioned the use of AI. And, I think the first thing is the data that we need are being identified. We did a lot of work to comment on the US CDI Plus. So from there, we can start looking at, take the data, and I know there's a lot of other folks like the CMS, Johns Hopkins, they're really working on maternal health data because it's very, very important. So if we can identify the data, then let's look at the data and see how we can convert the data into things that computer can carry, and by means of automation, I think it would really, really help.
I think so too. And I think we've got a call to action. I have just put into the chat window, a couple of things. One, the survey. Please do take time to take the survey, and we're going to do a relaunch to encourage more folks and bring others along with you and encouraging them to respond to the survey. That's number one. Number two, that I put in there is Reach will have our BYOL, that is Bring Your Own Lunch, as we do every year. This will be like our 5th year doing this, working group at the HIMSS conference, global conference in March. But along with that, I think there's 2 huge opportunities. Dr. Wolfman mentioned working on an article positioning our perspective on this topic, and I think we should take that opportunity to work together with her and her team to make that happen. And we can use some of the output from this particular program and some previous programs that are very relevant to help in engineering the craft of that article. And then number 2, Dr. K, you've got me inspired. I hope others fired up as well. I know I'm fired up to put together, work with technologists, maybe getting folks of the likes of AWS or Amazon or others to come together, and let's put on a large scale hackathon to encourage folks to bring forth data and see if we can't put some models and some algorithms alongside them, and maybe see if we can churn some different ways of ingesting various data and bringing them out in ways that are consistent and can be uniformed. I'm excited about that, guys. That gives us a look into 2025, which will be here before we know it, and a lot of things we'll have to put in place along the way between now and then to make that happen. Wow, what a great program today. And how amazing your commitment that you've stayed with us a little bit after the hour. We really appreciate you for having done that. Be on the lookout for the summary of this program. And before we leave, I just want to give a shout out to Kelsey and Aaron, who are both new members of our team here at Reach Healthcare. Aaron, our new marketing specialist. Wave for us, Aaron. And Kelsey, our new executive administrator, and the roles that they're going to help play in expanding this program, as well as getting us revved up along with Rachel and David and Valerie from HIMSS to drive this agenda forward for 2025. Whoever makes it into the Oval Office is going to have their hands full with us, that's for sure. So we're excited about what the new year is going to bring. So thank you all so much for being here today, and we'll see you next time in October, where our focus will be a showcase of innovations. And so that's a shout out to all those technologists and providers here on the line to reach out to us, because we'd love to showcase you for October. Take care, everybody.
Thank you.
Bye.
Bye.
Thank you. Bye, everyone.
Bye.